So hello everyone. This is my name is Gustavo Saposnik. I'm the editor of the World Stroke Academy for the World Stroke Organization. And in this opportunity, we have an expert in frailty and stroke, Dr. Nicholas Evans. He is the first author of one of the papers of the month that we selected from the WSA. Nicholas, or may I call you Nick?
Of course.
Excellent. So please, if you can introduce yourself.
So thank you, and it's great to be here. So my name's Nick Evans. I'm a consultant in stroke medicine at Addenbrooke's Hospital in Cambridge in the UK, and also a researcher at the University of Cambridge.
So thank you, Nick, for joining us. It's a great opportunity to have you. And let's get started with an ice-breaking question. Subconscious is a state of mind of which one is not fully aware, but which influence our actions and decisions. Is frailty in our subconscious or a subconscious phenomenon?
So I think it is and it isn't. So I think as physicians and as clinicians, we often recognize frailty, but how much actively we are doing that as an active process versus actually pattern recognition about people that are going to do well in response to treatment, perhaps those that aren't going to benefit as much. So I think there is very much we base it on our experiences. And I think as we become more experienced, we detect frailty because we see a lot of it in our clinical practice. But how much we actually then actively think about that process, and also as well actually about how much we actually think of it as frailty per se. Very often frailty gets sort of mixed up a little bit with aspects of aging, of multimorbidity, of disability. And actually, it's a slightly different phenomenon. Frailty, just sort of to kind of really sort of give it its sort of pure definition, is this loss of physiological reserve to withstand a stressor. And we know that across general medicine and across multiple medical conditions, it's associated with poorer outcomes, increased mortality, and poorer recovery. And we see a lot of it. So I think the fact is it's making it an active process to recognize frailty as its own distinct entity, separate from those other things that I've mentioned, and making it an active process about thinking what implications it has for our acute stroke care.
Thank you. That's great, Nick. You mentioned that in the article that 3 out of 4 patients admitted with an acute stroke may fulfill criteria for frailty, at least in some studies. So why do you think this common issue has not translated into more practical actions?
Well, I think it goes back to what we were just saying, is that very often it hasn't been recognized as its own distinct entity. So if we look in a lot of the research studies that we have done, is that very often age gets used almost synonymously then with frailty, and similarly with multimorbidity and disability. And these are, yes, they are related concepts and often overlapping, but actually they are distinct entities. And we can think about that in our own lives. We can think of sort of individuals who are perhaps in their 80s and actually physiologically living like they're 20 years younger, sort of cycling around, independent. You would think for all intents and purposes, they're 10 or 20 years younger. And equally, we can think conversely of individuals who are 60, so biologically younger, but chronologically are behaving more like an 80-year-old. And you can be frail without comorbidities, and equally you can have comorbidities and disability without being frail. So I think in part the reason why it hasn't had sort of the attention so far is actually it hasn't really been appreciated as its own distinct entity. And I think one of the things that we as the group writing the paper were very keen to raise awareness of is actually about frailty's importance as its own entity across all different facets of stroke medicine. So I think it goes to just reinforce it's an important factor that should be considered actively in its own right.
So this is based on a personal observation. You mentioned that, you know, some people may be 80 years old, but they may look 20 years younger. And the question is, Has there been any studies that associate, the socioeconomic status with frailty? So let's put in a way. So an 80 years old in Canada or in the UK may not be the same based on the, let's say, social stress or distress than, an 80-year-old in a different country under, developing country. Or so are there any studies that, compare frailty based on some other social or psychological factors?
Indeed. So I think it's a very complex phenomenon, and undoubtedly socioeconomics will have an impact on frailty. So it has been recognized as that in the same way that frailty raises with age, actually so too does it raise with then socioeconomic deprivation. So again, it's links to this idea of healthy aging. And very often frailty is almost then recognized as almost the converse of healthy aging. And actually then what can cause then sort of the unhealthy aging then, well, very often that does go along then with factors of socioeconomic deprivation. And there are some factors, be that diet, be it then associations with things like smoking. We know that quite a few of these are actually exquisitely linked then with frailty. So we have done some other work that was actually presented at the European Stroke Organization meeting last year, which shows that frailty is independently associated with vascular inflammation within atherosclerosis. So if you think back to then its biological mechanism, is that actually those cardiovascular risk factors associated with socioeconomic deprivation may well be driving then this sort of inflammaging type of process, which is very often then associated with frailty. So yes, there are definitely some links there. But that potentially gives us also an opportunity then for actually targeting measures to reduce the impact of frailty and reduce frailty itself. We see a little bit of that in cardiac rehab. There are some emerging programs of sort of multifaceted interventions, but it's not something that we've really started yet to develop within stroke. Obviously, if we look towards what they're doing, I think a lot of those things will be analogous coming back down to the vascular basis.
So reflecting probably based on your comment on the potential reversibility of some of the process to ameliorate frailty?
Indeed. I mean, so there remains a lot of discussion about how reversible it is. And actually, I think there's a reasonable body of evidence to suggest that actually frailty can be reversed. Again, it partly depends on how you consider frailty. So one of the big frailty syndromes is the loss of muscle mass, so sarcopenia. And actually, we see that in stroke when people are deconditioned, if they're largely immobile, and that loss of muscle. So again, interventional strategies then to try and maintain muscle bulk, and actually sort of some of these interventional strategies to reduce the factors associated with frailty, I think has the potential, to either sort of arrest any kind of frailty decline, or better yet, actually be able to reverse some of it by factoring in some of these aspects associated with frailty, like things like the weight loss, the muscle loss, and things like that.
So Nick, my observation in that, let's say in the last, 8 years that we have some acute stroke trials, especially with the endovascular revascularization. Frailty was not one of the common characteristics included even in table 1. So the question, imagine that I'm a trialist and I'm designing the future trial for revascularization therapy. What would be your advice for a trialist? Imagine that you are the consultant. What should I include in my design?
So I think there are 2 points on that front, and I think it's very often the sort of a common perception that actually the trial populations that we see, and in my vascular research I'm very conscious of this as well, is not necessarily always reflective of the clinical population we see. As we said, is that the Taylor-Rowan paper shows that 3/4 of individuals have a degree of pre-frailty or frailty that come in. So it's extremely common, but actually, a lot of the research studies there have exclusion criteria against a sort of more disabled, multi-morbid, and there's very often not an exclusion criteria based on frailty, but the other exclusion criteria almost end up then excluding frailty almost as a consequence. So as we all know, very often a lot of the trial populations are amongst more robust individuals, less frail individuals, typically younger individuals. So that then poses a challenge for us delivering clinical care, because it's great if I end up with somebody who is the more robust, younger individual where clearly thrombectomy is indicated, but what about our older, frailer individuals? And there's a large body, also there's more and more studies now that indicate that frailty has a treatment modifying effect in acute stroke for both thrombolysis and thrombectomy. It's an area ongoing, but I think it shows the importance that we need to be thinking about actually how we approach frailty, either, and I think this is where the 2 points are, either ensuring that we're including frailty as an important variable in any analysis, but also as well thinking about actually taking a step back and thinking about our study design, is that actually about trying to ensure that we're replicating a real world population that's relevant for you and I when we're on the shop floor delivering clinical care, is actually to say, well, okay, how can we better build up our evidence base for how these treatments, how individuals with frailty respond to these treatments? And it's important whichever way. Either it helps us prognosticate to know, well, okay, frailer individuals are less likely to benefit from this treatment. I'm not saying that that means they shouldn't have it, but actually in terms of being able to then think these are the individuals who are less likely to get the marked benefits that we sometimes see with thrombectomy and thrombolysis. But also as well, actually, even it's borne out that frailty, there's a risk sometimes that is of nihilism. Is people see an older, frailer individual and think, this person's not going to benefit. But actually, having robust evidence that shows there may still be benefit, or even if that benefit matches a more robust individual, I think it's really important there that we have that evidence basis so we can make an informed decision. So we either avoid that nihilistic approach, or we are better able to prognosticate for the older, frailer individual coming in.
Thank you. Very good point, and especially there is a recent publication, and we commissioned an editorial about the Japanese study on low revascularization therapy on low aspect scores. And at the end of the day, if we don't generate the evidence, people are extrapolating the results and may not necessarily be patients that may benefit from the treatment, especially when we have no measurements of frailty in that study. Anyway.
Indeed, and that actually highlights then another issue at the moment, which is something we flagged up in the review article, is that the number of different ways that one can approach the measurement of frailty. And I think taking the field forward, it's going to be important for us to think about actually which measures we are using, which are the best ones to employ, either from a research perspective and or from a clinical perspective. Because I think, like the same way as NIHSS and Rankin scores, we need to be able to assess frailty in a robust and objective way, but also in a way that is actually quick and user-friendly then for the individual that's doing it. And there are a number of different ways that we sort of highlight in the review article about how that can potentially be done.
Thank you. And finally, the question is, we are all busy clinicians, and I'm always looking for integrated and practical solutions. So the question is, I'm in my clinic. I want to, know, whether the patients I'm facing, what's the degree of frailty. So are there any tools, anything that I could practically use that is not going to take me more than 1 minute to have a metric, a measurement?
So there are a few, and again, we try and outline this in the review article, but the one that actually we use clinically at Addenbrooke's and is used sort of increasingly across the UK is the Rockwood Clinical Frailty Scale. So it's an ordinal scale of 1 to 9 that bases then your sort of your measure of somebody's frailty based on their overall function, what they were able to do, their overall well-being, sort of 2 weeks before, and that's a really important point to remember, is that it's not the individual that you see in the sort of ambulance trolley, coming out the ambulance trolley waiting for thrombolysis. It's how they were 2 weeks ago. So actually it's finding out the information of what they were doing then for themselves 2 weeks ago. Was this somebody who was independent, cycling around, actually sort of, kind of fully self-caring, or was this somebody that was requiring actually assistance for the activities of daily living and various other things? So the clinical frailty scale we use routinely on any admission across any medical condition aged over 65. And it, as we say, it's very user-friendly and is very quick to do. There are some other ways of measuring frailty. So things like indices, for example, we outline one in the review article, which essentially is, as long as it covers a range of modalities between different comorbidities, sort of lab-based values, their overall function, you can choose actually sort of 30 or 40 points there that you can base an index upon. And then obviously if they've got those points, that would be your numerator, denominator against the 30 or 40 points. And you get a score then between 0 and 1. Now, that in a hyperacute stroke setting is not necessarily that user-friendly, because it will take time to do that. But I think actually with electronic medical records, actually you can see how that could be generated reasonably quickly. So again, I think it depends on the setup in which you're operating and also the time in which you've got to make that call. So this was the reason why when we looked at our thrombolysis, our outcome in all ischemic stroke paper, we used the clinical frailty scale, partly because we're used to using it, but also as well is because actually it has translatability then to people seeing strokes on the shop floor. So it depends on the setup, it depends on the time one has available, but certainly to be able to make quick ones, quick decisions and assessments, we tend to use the clinical frailty scale.
On behalf of the WSA and the WSO, Nick, we would like to thank you very much for your thoughtful comments. And to the audience, please go back to the paper. It's a great paper, and we created an editorial that summarized the important points. Thank you, everyone, and thank you for listening.